Good morning, everyone. Let's start with today's topic, that is chronic osteomyelitis. The term chronic osteomyelitis is used for chronic pyogenic osteomyelitis. The causes are, first we'll look into the types. The first one is chronic osteomyelitis, secondary to acute osteomyelitis. That is, if the acute osteomyelitis is left untreated or misly diagnosed, or anything can happen, delayed treatment or inadequate treatment, it can definitely progress towards the chronic osteomyelitis. Second one, Gary's osteomyelitis. Gary's osteomyelitis is sclerosing non-separative chronic osteomyelitis, and Brodys is nothing but it is a special type wherein the defense mechanism is very active of the body, just focusing on the infection bordered by the sclerotic bone. It is just focused to that particular spot and it is not spreading. That is your Brodys sepsis. I'll be dealing with these all three in the future slides. Coming to the first one, pathology, how it occurs. First one, delayed and inadequate treatment. I've already told, if left untreated, acute osteomyelitis can undergo definitely chronicity of its own thing. Delay causes spread of the pus within the medullary cavity and subperiosteally. This may result in the death of the bony part. We already dealt with that. What is the death of the bony part? Known as sequestrum. Destruction of cancellous bone leads to the formation of cavities within the bone. Such non-collapsing bony cavities and sequestrae are responsible for persistent infection. Coming to the second one, that is your type and virulence. Definitely we saw that the virulence, higher the virulence, easier the spread of the infection, thus leading to more chronicity, more early attainment of the chronic osteomyelitis. Coming to the type as well, not only one type of Staphylococcus aureus is present, there are many types of Staphylococcus aureus are present. Depending on the type, the infective rate is very high or very low, thus having different classification. Coming to the third one, that is your reduced host maintenance. If the child has kwashiorkor or marasmus, there is definitely nutritional deficiency, which can lead to decreased body immune deficiency, thus prone for any infection, not only osteomyelitis, hence may get osteomyelitis. Now coming to the process of osteomyelitis. We'll learn the process looking into the video. First one, take an example we have already seen in the last video. I'm very fond of knee joint example in osteomyelitis. Taking the same example, removing the fibula out just to make you understand. This is nothing but the red color is nothing but infection persisting within the metaphysis. Now, and we learned that there are three routes of travel of the bacteria once it starts presenting its own action on the bone. It has three routes to travel. First one is medullary cavity, second one is out of cortex to come to lie within the periosteum space. Third one is the to the other joint line. Let's take an example of periosteal space. It will opt the Volkmann's canal to travel to the periosteum. It will come to reach the periosteum. So what will happen later? Sequestrum, that is the death of the bone due to cut blood supply, after which there is pus formation. So before the pus is formed, what will happen is the bone is dead, and that is due to cut blood supply. The bacteria starts growing, starts manipulating, which leads to pus formation, hence it is yellow in color. After the pus formation is seen, this gives a boost mechanism to the bone in order to develop itself into a new bone. That is known as periosteal reaction. The pus under the periosteum generates subperiosteal new bone. That is known as periosteal reaction. Now, after periosteal reaction is seen, just look into that periosteal reaction. What is happening? This is how it will look. The sequestra, which is surrounded by the infected granulation tissue, and the red color is the dead bone. The infected granulation tissue is trying to eat up the red color, that is your dead bone, that is known as sequestra, and which is surrounded by something known as involucrum, the green color structure. This involucrum is the dense sclerotic bone, that is again dead bone, overlying a sequestrum. This envelocrum may have some holes within it. These holes are known as cloaca or cloacae, however you are trying to present it. I would like to present it as cloacae. The bony cavities are lined up by the infected granulation tissue. Now, what is the importance of these cloacae? If the pus is getting filled up too much, the cloacae are nothing but the holes. The pus can come out of this hole, thus leading to abscess and sinus formation, as we saw it in the last video. Coming to diagnosis. Diagnosis is nothing but it is first one, again the same thing for acute myelitis, whatever we wrote. First one is presenting complaint. Here in chronic osteomyelitis, we have already formed, the pus is already generated, the time is out, the sinus is already formed. So patient will present with chronic discharging sinus out of the skin right from the beneath bone present under it. So whatever the quality of discharge, whether it is serous or whether it is pus related or what it is. Third one is history of extrusion of bony fragment from the sinus. Sometimes the infection has occurred, the patient doesn't understand, he has started weight bearing. This may lead to pathological fracture of only that part wherever the infection is present. If that pathological fracture is occurred, the fractured fragment can come out from the sinus hole through the skin out into the external environment, thus leading to history of extrusion of the bony fragment from the sinus. Fourth one, minimal pain can aggravate and fever. Minimal pain is present which can aggravate on weight bearing, and fever is definitely present which is a sign of infection. On examination, first one on examination is chronic discharging sinus. Sinus is fixed to the underlying bone. This fixation of sinus will definitely indicate infection is arising from the bone, not from anywhere else. Second point, sprouting granulation tissue may indicate sequestrum within the bone. If only pus is secreted out, the pus has accumulated. If granulation tissue is coming out from the sinus, definitely you should understand that sequestrum is already formed in the bone. The third one, sequestrum is commonly visible at the mouth of the sinus. If you just open up a sinus a little bit, you can see the sequestrum. That is the dead bone. Coming to the second point in on examination, thickened irregular bone. This is usually assessed by the comparison of the growth of the bone on the normal side. This is present because of the presence of involucrum and sequestration only on the infected bone. It is not present on the non-infected bone. Coming to the tenderness, I have been repeatedly telling that in acute osteomyelitis, tenderness is located into the metaphysis, whereas tenderness in chronic osteomyelitis depends on the type of joint and wherever the root of the infection is passing through. If the root of the infection is passing through in chronic osteomyelitis in the intracapsular joint, definitely the tenderness is located along the joint line. If it is not intracapsular joint and the root of infection is not crossing over the growth plate, it is just passing to the periosteum or medullary cavity, the tenderness is located wherever it is passing. On deep palpation, generally tenderness is found. It is mildly present in some cases. Coming to the point D, that is your last point, adjacent joint. Adjacent joint you may feel that adjacent joint is getting stiffer because of the soft tissue scarring in the infection area. Sometimes the muscles are two joint muscle, which if the soft tissue scarring is occurring on the one end, definitely the muscle becomes stiffer and muscle becomes tighter. This may leads to underlying joint stiffer. So adjacent joint may get stiffer. This is also associated to arthritis of the joint if it is pyogenic arthritis. Coming to investigation. First one, radiological examination, because it is already crossed, periosteal reaction is already occurred, sequestrum, involucrum is already present. Hence, you can also see, definitely you can take up the X-ray and understand whether it is osteomyelitis or not. Thickening and irregularity of the cortices, because there is entire disruption of the bony line because of involucrum and sequestrum formation. Patchy sclerosis because of the sequestrum. Bony cavity. This is seen as an area of rarefaction surrounded by the sclerosis. It is not black, it is not white, it is just the rare fraction. The last point, sequestrum. This appears as denser than the surrounding normal bone because because of decalcification which occurs in the normal bone. And granulation tissue surrounding the sequestrum gives rise to a radiolucent zone around it. A sequestrum may be visible in soft tissue as well sometimes. If it is present in soft tissue, definitely on X-ray you can see its shadow, not the entire border. Coming to the involucrum and cloacae may also be visible sometimes. Now, this was the radiological examination. Coming to the second point, this is how the process of osteomyelitis will look. Again, we'll look after it one at one single point. The first one is periosteum, seeding of the infection, and metaphyseal vessel, where the seeding of infection is taking place. The second image shows that it is spreading to the periosteum, leading to subperiosteal abscess. Third image, the down second row, will show that it is sequestrum is already formed along with the involucrum, and sinus is just generating. The fourth one is nothing but the discharge of the pus and the bone through sinus. Coming to the imaging techniques. Imaging techniques will include sinogram, CT scan and MRI, blood examination and pus culture will not come under imaging techniques. It is totally a different investigation. Sinogram. Sinogram is a test wherein a sterile thin catheter is introduced into the bone and a dye is injected in the bone. This radiopaque dye will travel to the root of the infection, thus helping localizing the root of the infection. So this will be definitely positive in the osteomyelitis because it is also infected. CT scan and MRI are sometimes indicated in the patient where the diagnosis is very much in doubt. CT scan is particularly used for better defining the cavities and the sequestrae, that is the borders of the cavities and the sequestrae, which sometimes can be very difficult to identify on the X-ray. And MRI, if the soft tissues are infected, as I already explained, that sometimes the sequestrum can also be present in or around the soft tissue. To localize that, definitely MRI would be better than the X-ray. Coming to blood examination, as it is infection, there will be elevated ESR. Also, total blood count may be normal and may be increased during acute exacerbation also. Coming to the pus culture may show definite causative organism. Coming to differential diagnosis. There are three main differential diagnoses in chronic osteomyelitis. The first one, tubercular osteomyelitis. The discharge in tubercular osteomyelitis is very thin and watery, whereas in a chronic osteomyelitis, it is thick and pus related. And also tubercular sinus may show its characteristic feature like undermined margin and bluish surrounding of the skin, whereas in chronic osteomyelitis it is usually the chronic discharging sinus as we saw in the presenting complaint. And also the causative organism in tubercular osteomyelitis is different, that is pulmonary tuberculosis, and in chronic osteomyelitis this is definitely different because of Staphylococcus aureus. Coming to the second point, soft tissue infection. A long-standing soft tissue infection with discharging sinus may mimic osteomyelitis, but there is definite absence of thickening of the underlying bone, which we saw in the chronic osteomyelitis. One of the investigative characteristics of the radiological examination, the first point was thickening and irregularity of bone, which is absent in soft tissue infection. Also, the tenderness is not located to the point where the infection is presenting, which is absent in the soft tissue infection because it may be related to some other place. Also, the chronic sinus discharge is sometimes may be absent in soft tissue infection. Coming to the last point, that is your Ewing's sarcoma. Also, I forgot one more point that I told in sinus, if it is fixed to the underlying bone, definitely we have to understand that the infection is present within the bone. It is absent in the soft tissue infection. Now, coming to the third point, that is your Ewing's sarcoma. A child with Ewing's sarcoma sometimes present with a rather sudden onset of pain, which is commonly seen in Ewing's sarcoma. That is sudden onset of pain and swelling, mostly in diaphysis. That is the only feature. because Ewing sarcoma is relocated to diaphysis, not metaphysis, which is a common site for infection for osteomyelitis. Coming to the treatment, the principle of treatment is basically surgery because it is chronicity. Chronicity of the infection is already crossed to the limit, hence we have to opt for surgery. The first point is removal of the dead bone. Second point is elimination of the dead space and cavities. Third point is removal of infected granulation tissue and sinus, thus in order to get a healthy bone. Now, there are different operative procedures depending on what is occurred as the infection proceeds. These are the types of operative procedure, that is sequestromy, saucerization, curettage, excision of an infected bone, and amputation. Let's look at it one by one. Taking an example of bone, that is tibia getting infected, as you already know that it's my favorite bone. Tibia is infected. You can see in the image that sequestrum and the granulation tissue beside the sequestrum has already occurred. As we saw, the first type of operative method is sequestromy. This means the removal of sequestrum. So hence that is nothing but your sequestromy. So the first one will be removal of sequestrum. The second one will be saucerization. A bony cavity is a non-collapsing cavity. You have to make this into a saucerization pan. This is responsible for persistence of an infection. If it is left untreated, it will be responsible for persistence of the infection after the removal of sequestration. Thus, you have to make it in a saucer pan by removing its wall. Thus, the sauceration is created. This is nothing but your saucerization. After saucerization, you need to do curettage, where the wall of the cavity, which is lined up, still this saucerization has some infective part, that is termed by the red color. You can see this is the thing but your red color, infected granulation tissue which is stuck to the saucerized part. So next procedure is removal of this infected granulation tissue, that is nothing but your curettation. So this is the end of the is this the end of the operative procedure, leaving the bone like that only as you can see in the image? No. If you leave it like that, some or the other infection can process it in a quicker way once the bone or the space is left open. So what you have to do that time? You have to fill it up either by a local muscle flap or by gentamicin impregnated cement beads. So this is how the end part of the bone will look after operation. The two other techniques for operative procedure are excision of an infected bone just to excise the infected part out, or amputation. If the infection is spread too much, then amputate the part out rather than carrying out the small procedures. Coming to the continuous irrigation system. Continuous irrigation system is usually in the system, it has an inlet tube going or reaching the medullary cavity and an outlet tube to bring out the irrigation fluid out. The injected tube passes the irrigation fluid, which usually drains out the pus accumulated and the infection with a slow suction, thus collecting the waste fluid out. The irrigation fluid usually consists of suitable antibiotics and a detergent so as to wash it out. This irrigation is usually done for 4 to 7 days. Coming to complication. The first one, acute exacerbation. Flaring up of the infection occurs commonly. It subsides with a period of rest and antibiotics. Second one, growth abnormalities. If the infection has reached the growth plate, it will definitely cause either shortening, lengthening, or deformity. Coming to the third one, pathological fracture. As we have already seen it in acute osteomyelitis, if you guys have not watched the last video that is on the acute osteomyelitis, I'll put up the link in the description box below. Pathological fracture may occur through a weakened area of the bone if it is loaded. Fourth one, joint stiffness may occur due to scarring of the soft tissue crossing the two joints. Joint stiffness is usually seen in the adjacent joint. The fifth one is sinus tract malignancy. It is the rarest complication of chronic osteomyelitis, which may occur after so many years after the onset of osteomyelitis. Usually, a squamous cell carcinoma is seen in these patients. patient may need amputation when it occurs. The last point, that is the sixth one, is amyloidosis. As with all other long-standing suppuration, that is your infection, this is also a late complication of osteomyelitis. So this was the end of chronic osteomyelitis. Let's meet you all in the next lecture regarding gregarious osteomyelitis and Brodys abscess. Thank you, one and all.